So our lecture tonight is A Day in the Life of a Foundation Year 1 Doctor from Dr. Oliver Pentz. Dr. Oliver Pentz attended a BSMS for 5 years with an intercalation year in Neuroscience at the University of Sussex in between and graduated in the class of 2023. While at medical school, he was involved in the BSMS Medic Revue and was MedSoc President for 2020 to 21 and 2021 to 2022. Dr. Pentz is currently working as an FY1 doctor at the Royal Liverpool Hospital, having completed jobs in psychiatry, urology, and currently working on a respiratory ward. At which point I will hand over to you, Ollie.
Thank you very much for that introduction. Let me get started with this presentation. It's always the most important part is making sure that the text actually working. Okay, is that working, Zach? Can we see the presentation?
Yeah, looks all
Yeah,
good to me.
great, fantastic. Yeah, well, thank you very much, everyone, for coming, and thank you, Zach, and the Outreach team for inviting me along. But yeah, so I'm just going to talk very broadly, kind of about a day in the life of an F1, as well as kind of like my experiences of what it's like being a doctor, and a sort of the other kind of things around being an F1, like rotors and leave and study time and things like that. So yeah, like we said, please put questions in the Q&A function, and we'll get to them at the end or at some point partway through. Yeah, so getting started. A bit about me. I think Zach said most of this stuff already, but oh yeah, I would note that so these two photos. This was my last day technically as a medical student when I graduated, and it was on a Friday, and then the photo on this side on the right is my first day as an F1 on the Monday. There's a pretty quick turnaround for being a medical student going straight to being an F1. Which is a bit of a shock to the system. But yeah, so again, just here's some nice photos of the things I got involved with at med school, which Zach kindly mentioned as well. Just my intercalation in neuroscience at Sussex. That was mainly just so I could kind of hang around BSMS and do more society things, like the Medic Revue and MedSoc, which I would encourage you to check out the Medic Revue. You can see these; they're all on YouTube. And I played football at med school and lots of other things. So, but that's that. Med school behind me now. I'm working as a doctor, and we will talk about that. So, again, when you start work as an F1, you get allocated 6 jobs. You get to rank them, but then you get allocated your 6 jobs. So, like Zach said, I started on psychiatry, and I did 4 months of that. Then I did 4 months of urology, and then now I'm halfway through my 4 months in respiratory. Next up, I will hopefully continue on to my F2 year, where I'll be doing ED, so A&E, then renal, and then finishing foundation on GP, which is very exciting. And I'll kind of talk a bit briefly about, different jobs I did and what my experiences were. I think the main thing, if any of you watching are medical students, or you might be thinking about what jobs you want to do in the future, I would say that broadly it varies so much from trust to trust on which jobs are good and which jobs are bad. And I don't think there's really any such thing as, urology is a good job to have, or respiratory is a good job or a bad job. I think it depends on what the trust is like. So for example, respiratory, I really enjoy it. It's really nice. The staffing's great. And it's a good work-life balance. Whereas I have a friend who's an F1 working in Croydon, where it's the opposite. The staffing's really poor. It's very stressful, lots of things like that. So basically, just kind of broadly, jobs vary a lot based on where you are. And so this is where I am in that picture. That is the Royal Liverpool University Hospital. It's a new hospital as well, which is amazing. So I'm the first full year cohort who is working there, which is great. And everything's digital, state of the art, and it pretty much functions, which I would say is kind of a compliment for hospitals generally, is that if it just about functions, that's actually a good thing, because I think the bar is unfortunately quite low. So anyway, so what I'll be talking about is we'll be doing a proper day in my life. We'll sort of be pretending we're all an F1 for a day, and we'll go through what my day is and what sort of things I get up to. Like I said, we'll talk about surgical days and my experiences briefly on urology, medical days, what on-calls are like, and on-calls include evenings, weekends, and night shifts. So, starting off, put yourself in my shoes as an F1. You have just woken up. Good morning. It is your first day of F1, and you are ready and raring to go, like I am every morning. You can see how fresh-faced I looked and ready for a day working as a doctor. So I walk up the hill from my flat in the docks and go to the Royal Liverpool Hospital, this lovely building here, and get started. So this is essentially my day schedule. This is the day in the life of an F1, um, where you start at 9 a.m., you kind of finish your day job at 5, and then if you're unlucky enough to be on call, you'll be working from 5 till about 9:30 as well, but that's kind of a bit separate, and we'll talk about that later. So the normal day job is just 9 to 5. You start the day off 9 a.m., like I said, doing a board round. You then prep your notes. You then see all the patients on the ward round, hopefully get some lunch. I've been quite lucky, like I said, with staffing. I've only missed lunch maybe twice in the whole of F1. Which is pretty good. But I know lots of F1 colleagues who, well, I wouldn't say lots. I know quite a few F1 colleagues who regularly don't get their lunch break, which is a shame. But I would say by and large, most people are able to get their lunch break. And then you spend the afternoon time doing some ward jobs. You then do a board round in the afternoon. And then, like I said, in the evening, you're on call. So we will go through each of those individually, what they actually mean and what I do and what an F1 is kind of expected to do. Like I've kind of alluded to already, that it varies quite a lot trust to trust. So in Brighton, where I trained, I was in Eastbourne, I was in Worthing, I was at the county, and even those three vary quite a lot in terms of how it works. As a hospital and things like that. So I would say is don't necessarily take my word for gospel for things I talk about, because, like I said, things can be quite different in different hospitals. But I'll try and kind of give a broad overview. Okay, so first up, like I said, we've walked into work, we're ready and raring to go, and we start 9 a.m. with the board round. And yeah, this usually takes about half an hour. And what it means is we have a list of all the patients that we're looking after on the ward. In my hospital, that's 28 patients. We go through every 28 patients, and you'd go through each of them and you'd say, this is a 82-year-old man who is being treated for an infective exacerbation of COPD. Then you do that for every single patient, and then we say what we're doing for them and what we need to do, which is part of the discussion. So it just kind of gives everyone on the team an idea of what patients we're looking after and what we're doing for them and what needs to be done. So it's quite useful, sets you up for the day. And like I said, the role of the F1 in that is to present the patients that you look after and to record the jobs for your patients. So usually on my job, again, varies a lot job to job, I get assigned a zone. So I get given 6 to 8 patients that are my patients for the day. So I do everything for them. So I'll present them on the ward round. So I'll say what I just said, this is how old they are, this is what they're diagnosed with, this is what we're treating them for. And then sometimes the consultant will be like, oh yeah, we need this, this, and this for them. And then I'll write that down, and then you can sort of action that later on. But usually, pretty straightforward. Start of the day, everyone's quite bleary-eyed. And I would say 9 a.m. start. And I actually try not be there for 9 a.m. I try to be a bit later because everyone else in my ward is late. And I'm usually on time, and I can't help myself be on time. But usually at 9 a.m., I'm there, the office is empty, no one else is there. Yes. So I think my experiences of F1, people have very different ideas of timekeeping. Yeah. So moving on, after the board round, we have prepping notes. Now, this part of the job could definitely be done by some like a robot or maybe even a monkey if you're feeling generous. It is basically just kind of like filling in this proforma, which you can see on the left is kind of an example of what notes look like in the hospital. A lot of you may have seen this already, but the F1's role and when you're looking after the patient. So for my 8 patients in this zone, or I should say for our 8 patients in the zone, the 8 patients we're looking after on our first day of F1, we need to prepare all their notes so that when we go around and see them, we can just fill in all the blanks, we can fill in their problems, we can fill in we can do all this stuff when we see them and then write in the plan. I would say this is one of the biggest variations between hospitals is in, I still think the last time I was in Brighton, which is almost about a year ago now, that things were paper notes. I would say probably about half hospitals are still paper notes where you have to handwrite everything. Whereas where I'm at the Royal, everything's online. So you can type things out, which is great because it means that you can copy and paste things. So for the whole top half of these notes, you can copy and paste it. But obviously you've got to check that, it's actually correct what you're copying and pasting. So that's what you do for about the half an hour. You prep your 7 or your 8 patients. Again, pretty boring, not that engaging. If you know the patients, it's probably even more boring because you know all that stuff and you're just copying it out. Whereas if you don't know the patients because it's your first day on that ward, or you might have swapped zones, or you've been off for a while, whatever, it's a really good opportunity to get to know them, because often the consultants will be like, oh, what antibiotics are they on? And they are, you may have heard, they're not usually the most patient of folks. So if they say what antibiotics are they on, and off the top of your head because you've spent the time prepping the notes to learn them, you can say, oh, they're on amoxicillin 3 times a day, and you'll look like a very good F1. Whereas if you don't know, you have to get it all up, and they might not be best pleased. But usually they're fine. Again, I'd say I've had only really good to sort of mid experiences. I've not had any bad experiences with consultants so far. Fingers crossed it stays that way. So we've got our 8 patients, we've prepped all the notes, and we're ready to see them on the ward round. The ward round, I would say, it's probably my least favorite part of the day. Not that I don't enjoy it, but I think I find it quite boring because sometimes they can last for ages, and sometimes patients can talk a lot. And often your patient list is quite long and you're trying to speed through all of them, or not speed through all of them, but you've got a lot of jobs you really want to get on with, and some patients are talking for quite a long time. So that can be a little bit tough. So sometimes it lasts for hours and hours and hours. I've had a ward round when I was on surgery actually finish at 3 p.m. and surgery finishes at 4. So we only had an hour to do all the jobs. So that was pretty rough. But usually on medicine, they usually finish by about 12 to 1, and then you can get some lunch. And I think this photo is quite accurate of what some ward rounds can be. Is sometimes you've got med students, you've got F1s, you've got F2s, you've got consultants. The whole team's coming along for a nice little stroll around to see the patients, and everyone listens to their chest, especially on respiratory. Like I said, there's some great clinical signs. I was going to say they're great sounding lungs, but I think it's the opposite of that. There's some terrible sounding lungs, unfortunately, but it's good for learning. And so when you see patients on the ward round, they are reviewed either by a junior, so that's an SHO, or an F1, that can be part of your role too, or they could be reviewed by a senior. And when you junior review them, now this is more common on sort of elderly wards, so geriatrics. There's a lot of junior reviews that go on there, and that's basically just you see them yourself, you write in the notes about what you think, if the patient reports anything new, and if you want to action anything for them, like if you want to prescribe them laxatives or anything like that. With the F1 role, I think the most important thing about being an F1 is knowing kind of what your limits of competencies are. So it's knowing what you can do yourself, what you can't do yourself, and what you need to ask advice about. So, for example, if I junior review a patient and they say to me, oh, this happens all the time. They'll say, oh, I'm feeling fine, but, I haven't opened my bowels in 5 days. Then I would be like, fine, I'll prescribe you some laxatives. And then that would be, I wouldn't escalate it or anything. Whereas, for example, if a patient says to you, oh, doctor, I've got severe abdominal pain, and you look at their observations and their blood pressure is really low, I'd obviously do a few bits myself, but I would always escalate that. If I think it's something that's, the patient's actually unwell, rather than just something small that I can do myself, I would usually always escalate that. And that's the important thing as an F1. Senior reviews, most common way that patients are seen. Some consultants like to see every single patient on the ward every day. Some consultants like to do half. It just varies, and they can do whatever they want because they are the boss. So when you see a patient with the senior, it is quite a different vibe, because when you're the junior, you chat to the patient yourself. You see what's up, you action the plans. Whereas for a senior review, you're kind of just sometimes at the back. You don't even say anything other than hello, just typing away or scribing away, which is quite similar to being a medical student. So that was always gives me a good throwback. So what you do is you go along with the consultant, and then you basically just document. So anything the patient says, you write down. And again, like I said, some of you guys might have experience with doing this anyway. But yeah, it's quite a big role of the F1, and it takes up about half your day. So we see all our 8 patients, we junior review maybe 4 of them, and we see 4 of them with the consultant. And then we can move on to the afternoon. Oh yes, one thing I should note is, like I said, because everything is digital in Liverpool, we have these amazing devices called cows. which stands for computer on wheels, which I think, coming from a place where everything's handwritten, I think they're great because you can type everything, you can look everything up, you don't have to flip through pieces of paper, you can copy and paste, you can find things. It's amazing. Only downside is it's also kind of the bane of my life because they crash all the time. And I mean that in both meanings, that the software crashes and you have to refresh it a lot. And sometimes the consultant will be like, oh, what's, their heart rate? And you'll like click on the thing and it will crash. And then you'll take ages to reload it. And the consultant will be like, how have you like not done this? But obviously it's not your fault, it's the computer. But they sometimes don't appreciate that, unfortunately. And then also crashing, I mean, literally, because I, again, have had some surgery ward rounds, probably the one that finished at 3 p.m., where I've been speeding around A&E in the acute medical unit, pushing this trolley at absolute high speeds down the corridor. And, if there's anything in the way, it's just going to get knocked over and you just got to keep going. And I have crashed it once or twice, I have to admit, because the consultant, if it goes, especially on surgery, if they go out of sight, if they walk onto the next patient without you and you lose them, that's it. They're not going to find you again. So I just thought I'd talk a little bit about the cows. Love them and hate them in equal degrees, I think. Oh yes, I've put a slide for a banana here because as it's now 1 p.m. or just before 1 p.m., it's time for the emergency banana. Every day, most days, I have an emergency banana, which is when I've been working hard from 9 a.m. and it's just before lunch and I get ravenously hungry. And I take an emergency banana just to pep me up, and get me through to the afternoon. And also because it's very easy, especially when you're busy, to kind of forget to eat and forget to drink and stuff. And I find that I get so grumpy if I don't eat. And I've had a few ward rounds where I've not really thought about it. And then suddenly I just get hungry. Suddenly I just get furious. And I'm like, why am I hating this ward round so much? And then I'll eat my emergency banana. I'll be like, there you go. That was it all along. So I'd recommend an emergency banana. Then in the afternoon, so we've done our ward round. We've had our delicious emergency banana. We've gone to lunch. So usually, I'll just say briefly about lunch. I take about half an hour to 45 minutes if there's not much going on for lunch. And I'll go up to the doctor's mess, which is a place which is kind of just for junior doctors. And I'll have lunch and there'll often be other F1s around. So it's kind of like a nice social break and everyone can commiserate over how their days have been, which is really fun. And they sometimes have free food there too, which is great. So then you have your lunch and then you do your afternoon ward jobs, and they completely depend on the patients that you see, obviously. So sometimes all 8 of your patients you won't actually need to do anything for, and you can kind of chill out in the afternoon or go help your colleagues. But usually they consist of prescribing. So like I said, if you think somebody needs some laxatives, you can just prescribe them some usual. I usually hit them with the double Senna and Macrogol, the absolute classic. Then you can also order tests. So if the consultant or you decide that the patient needs a chest X-ray, then you can order a chest X-ray, CT scan, MRI, any of that sort of thing. Ordering scans, like I said, and then procedures. So if patients need some bloods taking, or a catheter, or a cannula, or a chest drain, anything like that. As an F1, you won't be putting in chest drains, but again, depending on which hospital you're in and how skilled the kind of members of the MDT are, you might be expected to do lots of bloods, lots of cannulas, and lots of catheters. At the Royal, like I said, we've got a load of really highly skilled, nurses, which is amazing. So actually, as an F1, I don't spend that much time doing cannulas or catheters or bloods. I mean, I do, and I often do if I've not got much going on, jobs wise, but you don't actually have to do that much. Whereas I think in other hospitals that I've heard is you basically spend so much of your day doing this, especially on night shifts. You'll spend all night taking bloods and doing cannulas and stuff. So I feel we're very lucky that we've got the advanced nurse practitioners in Liverpool who do it for us. And also because they're so much more skilled than us. So it's a great safety net to have, is that if your patient desperately needs a cannula, it's 4 a.m., they need their stat antibiotic because they're floridly septic. If you miss the cannula, it's okay because the A&Ps can come and help you with it, which is great. And you don't always get that in hospitals. Also, I just would like to note this photo's AI generated. I used an AI to make this picture. It's the only one that I used in this presentation. As you can probably imagine, seeing is his hands are actually going through the computer, and the computer monitor kind of is a shadow or not even a monitor. But anyway, there you go. So that's the future of giving presentations, all AI generated. And his stethoscope looks a bit gross as well. Anyway, moving on. So yeah, like I said, in the afternoon, you action the jobs lists. And so I've done a brief example to show you what that actually means. So let's say, I mean, this wouldn't be in the documentation, but let's say it's a 85-year-old patient who's on the ward who, I don't know, came in with, I don't know, a heart attack or something. They've been treated for it, but they suddenly oxygen requirement increases and they start coughing up a lot of mucky stuff and whatever. So we might think that we're very clever F1s and we've assessed this patient and we think, oh, this patient might have a hospital-acquired pneumonia. So what we would do, this is exactly what a plan would look like. I lifted this from one of my notes. Is they would say CXR, IV, ABX, catheterize, bloods, FBC, CRP, U's and E's. What these all mean is chest X-ray is the first one, IV antibiotics, so that's just antibiotics given intravenously, so straight into the vein. 3, catheterize, so that's just monitoring their urine output, and that's just a tube that goes into the bladder, which I know too much about from doing urology as my second job. And bloods, so that's just doing bloods tests, and those are the investigations that you do for the bloods. Now, how you actually action these things, again, varies so much from hospital to hospital. And I actually think to be an effective F1 on your 9 to 5 job, knowing how to do these things, not even skillfully, like I don't mean being a skillful catheterizer, I mean just knowing the logistics of how to order a chest X-ray is probably the most important thing. Every hospital is different. I think in Eastbourne Hospital, when I was there, it's all paper and you have to literally handwrite like a radiology request form, take it to radiology and then put it in a basket and then they process it, which I think is like the dark ages for medicine. Whereas at Liverpool, you literally just press a button, order test, chest X-ray, type in why you want it, and then somebody will come and get them, which is great. So we order the chest X-ray for this patient. This is the chest X-ray, and I won't ask anyone to interpret it because I've been burnt by that so many times before, having to interpret chest X-rays. I remember as a third-year medical student, it was pretty brutal. But yeah, it looks like they've got a pretty good going pneumonia going there over on their right lung, sorry. And then next up, we need to prescribe them some IV antibiotics. You might have to do that on a paper chart, but I think the majority of hospitals nowadays all have online prescribing, which is so much better. It's so much safer and everything like that. So it's kind of a no-brainer. So you order the chest X-ray. So I just type on my cow. And I just type chest X-ray, order it. Next up, I open the EPMA, which is how we prescribe medication. I then search on the hospital intranet, which I've taken a screenshot of here, to tell me for hospital-acquired pneumonia, we give amoxicillin and clarithromycin, and you give a stat gent if they're in septic shock, but thankfully this patient isn't. So we just give those two, and it tells us exactly how much to prescribe and for how long. And it tells us all the details we need to do. So I basically just copy that over. Pretty straightforward. Not a lot of brain power needed to do this. And I think that is probably true for a lot of the F1's job is, a lot of my job is there's not a lot of brain power. I feel like 80% of your job takes about 10% brain power, but then that last 20% of the job does take quite a lot of brain power. But I'll talk about that a bit later because that's usually more when you're on calls. So there we go. We've checked the antimicrobial local guidelines, and they'll be different in different hospitals. So we prescribed the antibiotics. And then, like I said before, with the catheter and the bloods, the catheter, if the nurse is feeling generous, one of the nurses might put them in. Same thing with bloods, they might do it, or you might do them yourselves. And again, you can just order the bloods and print them off. So there you go. We've just sorted this patient out. We've got them a chest X-ray. We started them on antibiotics. We've catheterized them, and we've got their bloods. And the other thing as well is that you've got to make sure that whenever you do a test, again, I think that's an important thing of F1 to never forget. Every time you do a test, you've got to make sure you or somebody looks for the result of that test. So if you do some bloods, you've got to make sure somebody checks them. If you do a chest X-ray, you've got to make sure somebody checks them. Most of the time, it will be you because you'll be able to order these investigations in the morning and check them in the afternoon. But sometimes if the bloods are taken late or there's a delay for whatever reason, you can hand it over to the team in the evening to do. That's because even if they're just routine bloods, so if they're just bloods that you take every week just to see what's going on, sometimes patients can have results that are, an emergency and need something managed. So they could be, like they could be hyperkalemic, which can be a medical emergency if their potassium's super, super high. So that's why you have to hand over everything, even if you think it's going to be normal, because just on the 1% chance it's not normal, patients can be severely harmed. So it's important to remember. Okay, so we've done our 9 to 5. We've finished all our jobs. We ticked everything off. We've given everyone antibiotics that need them. We've done all the chest x-rays. We've looked at all the bloods. Everything looks normal. Then we wave goodbye to our lucky colleagues that aren't on call for this evening. And we go to handover. So handover is usually at 4:30, and that's just where all of the people who are on call go. And it's if you have any patients that you think are really sick, or there's any outstanding investigations that urgently need to be done, you can go to handover and tell them about it. So let's say we're on the respiratory ward, and at 4:15, one of our patients suddenly gets really unwell, has a really high news score, and needs some antibiotics. And various other things, or has a cardiac arrest or anything like that, anything really emergency. It's good practice to take that to handover and just tell the person who'll be looking after them in the evening a bit about that. And also, it means that you can hand over some of the jobs so that they can do, so that you don't stay too late. One thing I would say about handover that I was a bit worried about, I think, starting F1, is I was worried that I wouldn't know, what was acceptable to hand over and what wasn't, because everyone always says you have to hand over all your jobs at 4:30/5 and then go home. But actually, it's kind of not really acceptable to hand over simple day jobs such as ordering chest x-rays or doing bloods or anything like that. That's mainly because, you should do them during the day. And if you don't have time, which definitely does happen, then it's kind of, you should stay late to do it a little bit. I mean, you're not forced to stay late, but I think it's pretty much everyone I know does stay late to do the simple jobs, and anything complicated you can hand over. Yeah, so that's pretty much it. So you go to handover, and then how it works in my hospital is that because the staffing out of hours, so after 5 and overnight and on weekends, is a lot lower, because of course most of the people go home, or most people are asleep on nights and things like that. It's a really good thing because it means that, it's a good thing because the fewer staff you need to have the hospital out of hours, the fewer out of hours shifts you need to work, if that makes sense, because they're all spread out. But in my hospital, to get us more experience of different wards, we basically cover different wards that aren't our day job. So just last week, I worked 9 to 5 on respiratory, and then from 5 to 9, I covered the cardiology wards. So I would go up to handover, say, does anyone have anything to tell me about on the cardiology wards? They'd say no or yes or whatever, and then I'd basically start covering those wards. Just briefly to mention about on-calls, like I said, it basically means, I suppose the name comes from when you're on call, which is that, anyone can call you and you're kind of like the emergency doctor. And they consist of, evenings, weekends, and night shifts that you unfortunately have to work. You don't have to do any on-calls on GP or psychiatry, or some F1 jobs when you're supernumerary, which is great, but it does mean that you get paid a lot less. So I will talk more about on-calls, I think, because like I said, this is kind of, proper doctoring, I'd say. And this is where you definitely earn your earn your £15 an hour and more. I would say I would be bold to say more. Oh yeah, so this photo. Oh yeah, so I forgot about that photo. That basically the number one rule that I was told about night shifts in particular is, but also I suppose weekends and evenings when you're on call, because nobody wants to be on call. I do enjoy them, but the shifts are very long. Is that you eat whenever you want and whatever you want. So to treat yourself. You also on nights sleep, and I suppose on weekends if you're feeling lucky, sleep whenever you can and whenever you want. I mean, I don't sleep on my night shift generally, but some people like to. And depends how busy you are. But yeah, so this was my sleep, do whatever you want to treat myself. So every on call, I'm a little bit bougie. I get myself a Diet Pepsi and a packet of chili heatwave Doritos that I have for my dinner as a special treat for working so hard and so late. So these delicious snacks get me through. And you can also see my lovely dinner that actually looks disgusting now, but I can promise you it tasted pretty good, of spaghetti and some fake chicken. So that was very nice. So you can imagine we've worked hard all day, 6 p.m. You know what? We deserve a treat. And this is what you get. So the main, by and large, things that you have to do for your on-call and why it's proper doctoring is it's to review patients. Like I said, you do junior reviews during the day, but that's seeing patients that have established problems that we already know they've got pneumonia, or we already know that they've got they've had, a hypo, or we already know this. Whereas on calls, because all that sort of stuff that we know about has been managed during the day, on calls are all about the problems that crop up out of hours that nobody has known about already, or things that go wrong, that sort of thing. And also they can be clinical procedures. So maybe if you need to do bloods or canyons, like I said, I don't do that many on my job, which is lucky. So it's reviewing patients, and a few examples of that will include, please review this patient because of they've got pain, or so please review prescribed analgesia for pain as appropriate. There's a lot of that out of hours, a lot of pain. Please review these bloods. So like I said earlier, that could be that they were taken late, and you need to chase them just to make sure everything's okay. And also, please review this patient. Now, like I said, that's the big one, because it could be like, please review this patient. They're complaining of chest pain, and they could have had a heart attack. They could be having just sort of like muscle pain. They could have a pneumothorax. They could have a PE. There's so many different things it could be. And those things do happen. And obviously you don't know what it is until you see them. So that's the exciting part of it. And like I've been going on about as well, you can see in this photo, this is a picture of me hard at work at one of my on-calls. I'm full up of my diet Pepsi and Doritos and my dinner, and I'm working hard. And so, like I've been going on about with everything being digital in Liverpool, is that we are so lucky that our system for on-calls is we have basically a software that people can put our jobs on, and we could check them whenever we want and kind of work remotely for them. Obviously, maybe about a quarter of jobs you actually need to go see the patient because it could be reviewing them. But a lot of the prescribing jobs you can just do from, this is the doctor's mess, the photo where I am. And you can sit up in the doctor's mess with all your pals and just type away and talk to the nurses on the phone and stuff like that. You don't actually have to go down, which saves so much time, which is great. And it makes on-calls, I think, a lot more bearable because, you've got the social aspect and you can kind of relax a bit in the mess. Whereas on other hospitals, it's all through the bleep system. So I'm holding a bleep there, and we sort of use them at our hospital, but not that much. And it's basically that if anyone in the whole hospital needs you to do a job, then they bleep you, and you have to pick up the phone and say yes, like what do you want, or yes, what can I do for you is probably more polite. And then you basically record what they want you to do, and then you go do it. The problem with that is anyone can basically bleep you about anything, and often it can be kind of ridiculous things that you don't need to do. Whereas with our system, the nurse practitioners, which I spoke about before, they triage them. So they read through all of the jobs that we get allocated and take off the ones that are kind of not really relevant, and assign how the priority of them, and also do a lot of the jobs for us. So it's a really nice system of us all working together, because sometimes people will have like I saw one, this was before the nurses triaged it and got rid of it, where nurses will put like, which, 99% of the time they're amazing members of the team, but sometimes they put things like in all caps, they'll be like, patient needs sleeping tablet, patient is already asleep, need to come prescribe the sleeping tablet so I can give them it so it can help them sleep, all caps, and put as an immediate job. So it's like a big red flashing thing saying that exactly how I said it. In those exact words, didn't really make sense, but that's what it is, all caps. But that sort of thing, the nurse practitioners get rid of it for us, which is good. And sometimes you get really funny things because people with like misspelling or whatever. I think one of the ones that I found that I just couldn't stop laughing was probably because I was delirious from working my on call. It's probably pre-Doritos, but it was that they basically put like, attempted to pull out patient's rectus sheath, have failed, and that was it. And they meant rectus sheath catheter, which is kind of like a drain that goes into your abdomen, because the rectus sheath is obviously part of your anatomy. And so I was like, I really hope that they didn't try and actually pull out the rectus sheath, because the patient would have been in a lot of pain. Anyway, so those are the on-call jobs that you do, and that's me doing some good on-call jobs. And like I said, with reviewing patients, here I am reviewing an important patient. The concerning thing about this patient, though, is that the patient actually had a heartbeat, which is a little bit spooky. But so what you do is you do a full history, you do a full examination, you might order the investigations, and then you'd think about escalating as well. So like I said, that's a really important thing to know as an F1, is when and when not to escalate. But that was what I was quite worried about with starting, is to knowing, what's appropriate to escalate and what isn't, because you don't want the med reg to be like, stop phoning me. This is like really boring or whatever. Like, you don't need to call me about this. But I would say whenever you see a patient, unless they're critically ill, then you can put out an emergency call, that you do a full history yourself, you do a full examination. Even if you're wrong, it doesn't matter. You then order all the investigations that need to be done. So you could take their blood, you can do an ABG, anything like that. And then you don't have to wait for them to come back, but then you can talk to the med reg and say, if you're still worried, or just to double check that you've done everything correctly, you can say, I've done these things. What do you think I should do? Then the med reg can be like, oh, you can do these investigations and these other tests and you can action them. Or the med reg will be like, I'll come see the patient for you. So I think that's the main thing. And I would say as well that, the med reg is never going to criticize you if you've done all the investigations first. If you call the med reg and say like, oh, this patient's got chest pain and don't have any other information, then obviously I think they'd be fair enough for them to be annoyed. I would say as well, at the end of F1, where I'm at now, which is quite exciting, I'm definitely a lot more confident with what I can manage myself and what I don't. Whereas when I started as an F1, I think I ran pretty much everything by a senior doctor, which is good. I think it's good practice until you get a bit more confidence. Okay. Oh, yes, I was just going to briefly touch on what a typical surgical day is, because I think we're coming towards the end. Surgery is a lot less structured. It's a lot more just ward round. You see all the patients you need to see, and then you do all the jobs that you need to do. And that's basically it. Sometimes the ward round finishes at 10. Sometimes, like I said, it finishes at 3. But impossible to know. And sometimes you get theatre time on surgery. Again, depends how busy you are. I basically didn't really get any because I was too busy with my day jobs on urology. But so I think that's one of the big downsides of a busy hospital where I am, and then one of the plus sides of the smaller ones. If you're really keen on surgery, then that would be better. Just briefly, I was going to mention Met calls. So as an F1, you can also be part of the Met team. So one F1 is on the Met team, which means that it's like 4 or 5 doctors who, if there's an emergency, your bleep basically goes off and say medical emergency, this ward, and you fast walk to that ward and see what's going on. So that's if a nurse is really concerned about a patient, or maybe sometimes doctors put them out as well. So if somebody has like a cardiac arrest or something, or is really, really unwell, this is what they're for. Your role in Met calls as an F1, usually scribing, so that's just typing. You don't have to do anything. A lot of people take that role because it's usually the senior doctors who do the leading, but it is always good practice to try and get as involved as you can in the Met call. And I've actually only been on the Met bleep once, so I haven't actually been to that many Met calls myself, but I want to get practice at dealing with the emergencies. And in the top right is a nice photo of some people who have the Met bleep. I have no idea who they are. It's from the internet and it's not AI generated. So that's kind of the day in the life. I've done a very speedy overview. I appreciate I've spat out a lot of information, but I wanted to squeeze in everything. I'm just going to touch briefly on a few other the important things about being an F1, which is the rota. Basically, the rota is, like I said before, 3 4-month blocks of jobs, and you change every 4 months. My rota is pretty much about 1 to 2 evenings. So that's the on-call evenings that we were just talking about. I get about 1 to 2 of those per week, but it varies quite a lot. In the 4 months, you work about 1 weekend a month, and you work maybe 1 or 2 weeks of nights during the 4-month block as well, depending on how lucky or unlucky you are. The weird thing is, though, is you all get paid the same on the same jobs. Even if you do 2 night shifts, 2 weeks of nights, you still get paid the same as somebody who only does 1 week, because they average it out, which is kind of annoying. And then you get 9 days of annual leave, which is actually very decent. It's a good amount of leave per rotation, and it's a bit of a nightmare to book that in. But you get 9 days of leave. So this is just what my rota looks like. This is a particularly bad month, I will say, so don't be too worried. Is that I do 4 days of nights. I have the Friday off, but I finish Friday morning, weekend off. Then I've got my normal working day, and then this is basically normal working day. Then I have 2 days with on calls. Then I have a Friday off for free, which is amazing. Then I've got 3 days. The Thursday off is a rest day. Then I'm working the long weekend. But that's just kind of what it looks like. And it's a lot of hours, but bearing in mind, you've got study time booked in there, which I'll touch on briefly, and your 9 days of annual leave. So study time, you get 4 days total of study time per rotation. So this is for maintaining your portfolio, which you have to do. And if you want to get involved in any audits as well, anything like that, that also translates to 2 hours a week different places do different things. So my current job lets me do 2 hours every week and I book it in. Whereas my previous job, I basically just got 4 extra annual leave days, which was amazing. And like I said, you use it for audits, presentations if you need to, because you have to do an audit or be involved in an audit in F1. It's very easy to get involved in them, I would say. And you have to do a presentation. Sort out your portfolio, or my favorite, video games. I have to say I spend a lot of my study time playing video games when I don't need to do anything, but don't tell my bosses that, please. So that is pretty much the end of the presentation. I think that's, oh yeah, I was going to briefly mention pay, because obviously it's in the news and they've just announced, oh yeah, I was going to say as well, this rota is actually a bit different because on the 27th, 28th, and the 1st, I'm striking, so I actually am not working those days. So it does make it a lot easier. But yeah, briefly going to say about pay is that I would say as an F1, I found that the pay is actually not terrible overall, but the hourly rate is terrible. Like, £15 an hour for what we do. I personally, I think is like nothing. But because you work so many hours, you end up like, you can live relatively comfortably once you've paid off your overdraft and stuff. So my take home as an F1, depending on when I'm doing psychiatry, which you do fewer hours and fewer on calls, probably ranges about, so this is after tax, it's about 2,000 to maybe 2,500 if you're lucky, pounds per month, which is your take home, which I think, which I found is good. It's enough to save as well as spend. I'll briefly touch on, so we're coming to the end, but I'll just say positives and negatives. I feel like a lot of the positives in F1 are the same as the negatives. It's still a training role, so people are quite forgiving if you make mistakes, or which you will, as everyone does, as I have, as every doctor ever has, which is good. But then the downside of that is the training might be poor. Sometimes you don't get. So I definitely have had days at work where I've been like, I'm just doing admin. I haven't learned anything today, which is a bit of a shame. Positives again, social life. When you move to the new city, if you do move to a new city, everyone's in the same boat. Everyone's an F1, which is great. But the negatives are it's so hard to find a time when everyone's not working. That's one thing that is I really miss from med school. Positives, having salary. It's great to have more money than as a student. Negatives, like I said, salary is low, hopefully for not too long. Well, at least the hourly rate's low. Colleagues, best part about working in the NHS, a lot of lovely people out there and people you wouldn't meet otherwise in day-to-day life. It's rewarding. I'd say I have lots of days at work where I think, I feel like I did a good job. I really had an impact on this patient and their family, and I found the work I do is really valuable. So that's really nice. Some days I have the opposite, but that's I think that's the same with every job. And I couldn't see myself doing anything else, even though not every day is amazing. Pension's really good, apparently. I don't really know much about it, but I just know that the pension is excellent. And annual leave, positives and in the negatives. Positives that you get a lot of it, like 9 days, I think is so it's 27 days per year, plus the 4 study days, 12 study days per year is better than most starting jobs. But the negatives are sometimes it can be hard to book it in. If you have been allocated night shifts and you want to take leave over that week of nights, you have to swap it. Otherwise, they won't let you have it. Same with all on calls. Unfortunate. Anyway, I would say overall, I've had a very good time. I really like my job, which is good as well, because apparently everyone always says F1's the worst year of being a doctor. So it's only up from here, which is nice. I would say the main thing I don't like about F1 is the fact that it's a job. Is any job. I just don't like. I just find working 48 hours a week is pretty draining. But apart from that, that's the only thing. That's really my only major gripe. So I'll finish there. I think perfectly on time for 15 minutes of questions, I think.
So I think we've had a few questions come in, Ollie. So yeah, you can crack on answering a few of those.
Sure. So starting with I'll just go top to bottom, or speed through them. So if you had to redo med school, what would you do differently now? And would you choose medicine again if you were 18, knowing what you know now about the field? So I think what I would redo differently about med school, and this is maybe, a lot of people wouldn't tell you this, but I would say basically I find lectures like this lecture, I just find it doesn't work for me in terms of learning, and I don't find lectures engaging. And some people do, and it works really well for them, and I think that's great, and I'm very happy for them. But personally, I didn't pay much attention in kind of any lecture in med school, apart from if it was like patients coming in, because that was always interesting. And I remember being really like, oh my gosh, like will I still be able to pass med school? Like if I don't pay attention in lectures, and stuff like that. But now I'm proof now that that it's fine. Like I would say probably 95% of all of my finals revision was not done from the lectures we had from med school. It was all on Zero to Finals, Pass Med, all these websites that you'll either know about if you're a med student or you'll get to know about. So I would say I wouldn't feel bad. I wouldn't feel as kind of bad about not doing work at med school, and that's probably nothing else different. I mean, I did so as as you saw from like the photos and stuff. I did pretty much as many extracurricular activities as I could, and I spent more time doing that stuff than I did doing med school, and I don't regret that because that was great. And I kind of went into it knowing, I'm going to be working eventually, so I might as well get all that stuff out of my system, which I did. And now I wouldn't want to do all that again because that was, it was pretty draining, but it was very, very fun. And I said, would I choose medicine again if I were 18? If I was 18, I 100% would. And I just think because it's really worked for me and I really enjoy it. A lot of my friends who are F1s maybe wouldn't. But I think that's just a personal thing. And personally, I definitely would, because again, I couldn't see myself doing any other job. Like a lot of my, non-medic friends hearing about their jobs, and I'm just like, that just sounds so boring. I could never see myself doing that. Yeah. So there you go. I hope that answers your questions. Will I always be working in Liverpool? So I only have to work 2 years minimum in Liverpool, and I probably won't stay around. I think in Liverpool, I might come back to Brighton actually. Well, I'm going to go to Australia for a year as the plan for F3. It's classic. A lot of people do that, and then I'm going to come back and probably start my training, which I hopefully am going to do paediatrics training. So I want to be a paediatrician, which I think answers one of the later questions as well. So that's my plan: F3 in Australia, and then maybe back to Brighton. But no, yeah. So you only have to do your 2 years in where you get assigned for F1. Wanted to ask, what do you get in your exams and A levels? I would say all you need in A levels, I think, is still 3 A's. I think is that right, Zach, for BSMS?
Yeah,
But
typically
yeah,
it's 3 A's.
yeah.
There's lots of information on the Medical Schools Council has a full. They've not released their stuff for 2025 entry yet, but they've still got the 2024 entry stuff on there. They've got a full list of all the medical schools in the UK and all their entry requirements and whether they have contextual requirements, etc., etc. So do have a look on there when you're looking at for specific entry requirements. Yeah.
Mm. And so I would say that anything, you don't need anything above 3 A's. Like obviously it's good to get, but at least in my experiences, it doesn't matter whether because I also did 4 A levels, but it literally it hasn't helped me at all, and I could have done 3 and it would have been fine. So it didn't matter. I think maybe there was one. I think maybe when I applied to Birmingham, it meant that I would have a slightly lower offer for 4 A levels, but again, that's just I would research that. So do you do F1 while in med school? So F1 is you graduate medical school and it's your first year of being a doctor. So that's what being an F1 is. How hard was it to get into medical school? I would say, it's not easy, but there's a lot of resources out there which you can use and practice. And I'm sure Zach has and his team work really hard at helping people get into med school, and it does happen. It's med schools are as big as they've ever been, and they're accepting as many medical students, the most medical students ever. So what is the hardest part about being an F1? I think, like I said, it's just the hours. It is a lot of time, it boils down to 48 hours a week. And I think there's just so often, because I play football. So actually after this, I'm going to go play football with some other doctors, which is really nice. So I've kept up doing fun stuff. But there's some weeks where I basically can't do anything social. Like 2 weeks time, I'm on a week of nights. And because they're 12 hours long and because you sleep during the day, you literally can't do anything. And it is quite, it's quite depressing basically being like, for this whole week you're completely out of action, you just can't do anything except work. I would say that's the hardest part. In terms of actually being a doctor, I felt BSMS prepared me for that, and a lot of it you learn on the job anyway. Specialty, so I mentioned pediatrics. That's my top choice so far. A lot of people changed their minds, but that was my favorite in med school. I really like working with children. And you might have noticed I don't actually have a pediatrics job, which is a bit of a shame, but I'm going to do a taster week and hopefully work in that in Australia. What are exams like in F1 and in med school? Well, that is a good point. I didn't even mention that there are no exams in F1, which is so good. So you don't have to do any extra studying if you don't want to. So when you get home from work, you can just chill out. which is nice. Med school, I would say exams in med school. I actually found my GCSE exams the hardest of all exams that I did, including medical school, including everything. Because when you do, whatever, 10, 12 subjects or however many you do nowadays, especially if you want to get into medical school, trying to get all of those subjects up to like a sort of was it 7, 8 or 9 standard. That's just really hard to do, to kind of balance all this stuff. Whereas I found that's A levels, you have way fewer subjects. Med school, it's less. So I think it's actually GCSEs were the hardest. And med school exams, they're like kind of, there's practical ones where you simulate talking to a patient, and then there are other multiple choice ones about medical things. But I wouldn't say they're actually that useful for F1. What motivated you to keep going in med school and F1? I think the motivating things are, just that I think I really enjoyed it, and that at least for me, the best things about medical school wasn't the actual medicine, really. I enjoyed it sometimes. I enjoyed some of the parts of it, but for me, it was kind of like the social side, the activities and things like that. Those were the best parts of med school. I had some days in F1, sorry, not in F1, in clinical placements at medical school that were amazing. Like some of the best days, it's probably some of the best days of, the experiences I had. Like I got to assist in, some C-sections and help deliver a few babies in 4th year. And that was absolutely incredible. So those days are quite motivating, because I would say normally as a medical student, especially in retrospect as an F1, like some of the days are terrible. You kind of just traipse around following this consultant who completely ignores you. And, you don't really do much. But I would say not to put you off being a medical student, because again, some days are absolutely amazing and you get really, really good teaching, but it's just kind of like knowing what's good and what isn't good, and then you're working your schedule around that. So I knew that I didn't enjoy ward rounds as a medical student and didn't get much education out of it. So I just wouldn't spend much time. I just try and avoid them as much as possible. Best advice on how to get in and what made me pick BSMS. I would say, just practice interviews. There's a lot of resources out there. And I would say maybe pick BSMS. It was actually because of the student satisfaction. So when I applied to BSMS, I think in the overall ranking, it was ranked like maybe 25th out of 30 or something, which generally ranking doesn't really add much, I think, to med schools. It doesn't mean much, because you all graduate at the same, and it doesn't matter what med school you went to at all for your career, which is really nice. And I chose BSMS because I was like, 98% of people who go there recommend it. So why would I not? Whereas there are other med schools out there with like 60% satisfaction that are ranked higher. Whereas actually now I think BSMS is ranked so high anyway, it doesn't really matter. So I would say, what types of grades did you get in med school? Oh yeah, so I talked about that already. Yeah, it's 3 A's for my year that you needed to get into med school. Were you a top student? I would say, I suppose that's relative. I would say I worked hard at school. And did well in my exams. But I do think, like I said, that there's a whole range. I know loads of people who, didn't actually do that well in secondary school and got distinctions at medical school. They were in the top 10% of their year in medical school and did an absolutely fantastic job. I know people, actually, my partner who's an F1 as well, and lots of my other friends did resits for their A-level exams and got distinctions in medical school. So yeah, you don't have to be top. I'll speed through them because we're running out of time. What did you study and how did you study? I would say everyone has their own study technique and you need to find what's good for you. For me, different to a lot of people. A lot of people write notes. I basically just kind of I would look at the presentations and kind of like recite them in my head. That's how it worked for me. Wouldn't work for lots of other people, would work for some. I think you've just got to find your own way. Different hospitals have different procedures for how to immediately act on different scenarios. How do you get used to those on F1 when you're still new? Basically, they're quite good with doing inductions, so they'll hopefully tell you in your induction. And then also, like we had I didn't actually mention this, but before I started F1, we had a whole week of induction where it was just lectures for a whole entire week at the end of July before we had our first day, and they told us how to do a lot of these things. I think a lot, yeah. So I think you're right. I would say most of them have like met calls but I think in Brighton they have met calls as well. What rotation you found most interesting so far? Probably respiratory. I really like medicine. So I'd say psychiatry wasn't for me. I found it quite boring, but some people love it, and that's fine. And again, personal. How do I study? Mentioned that already. I would just say, find what works for you. I would say, if writing notes doesn't help you remember things, then don't do it. Find a different way. I feel like you shouldn't really, and that's why I didn't really like having so many lectures at med school, because it was mandatory for us to attend them back in my day. Whereas now I think it's a bit better that you can just watch them online. So I find that didn't work for me in terms of learning. So I heard that medical school is quite expensive and most people go into debt. That's true. I would say yes, medical school can be expensive. I would say when you say debt, I mean you get a free overdraft as a student bank account. So I had my overdraft maxed out at one point, but you pay it off pretty quickly as an F1. Um, and I don't know anyone who's gone into like proper debt like outside of just overdraft. So yeah, if we do I have time for a few more?
Yeah, go
Oh, briefly. Yeah.
pick maybe two more that you
Okay, yeah,
think are really
sure.
good ones. Yeah.
So I would say, yeah. So, let me let me find one. Why did I want to do medicine? That's a good interview question in the first place. I think combination of, I mean, it's a pretty bog standard answer. I just really enjoyed science at school. And I think the main thing for me was kind of like that you work with people so much. And I really like talking to people and kind of engaging with them and communicate. I just really enjoy communicating. And I would actually say didn't mention the presentation, but one of my favorite parts about the job is actually talking to patients and explaining to them what's going on with them, with their health problems. Because I found so often most patients have no idea what they've got wrong with them or what we're even doing for them. Which I find quite shocking. So I like to spend the time to explain it to them, and I really enjoy that. And finally, and in terms of free time, you do have free time in the. I mean, like I said, I'm quite busy because like I play football, I do climbing, do various other things too. But you do have time to yourself. Like you do work more than other jobs, and I would recommend yeah, BSMS is a good place. And finally, I think the question: you get paid about 2K a month after taxes. What about fields with more hours? So on psychiatry, I got paid about £2,000 per month after taxes. Whereas on my current job, where I do lots of out of hours work, I get paid about 2,400, I think, per month is about the take home. But it varies a bit with student loans and various different things. So it ranges. Yeah, that's pretty much the range. Cool. I think that's
Excellent. Thank you
the last
so
two.
much, Ollie, for this evening's lecture. It's been really, really interesting. I can see that there's a lot of we've had so many questions, and it's been great to see so many fantastic questions as well. So thank you again to Dr. Oliver Pentz for giving up your time this evening. It's been a really, really interesting lecture. Thank you to everybody who's come along. Please enjoy the rest of your evening, and we hope to see you at another session soon.